Liyaskar, and his topic is peekaboo.
So good morning, everyone. Presenting to you a case of a 51-year-old gentleman who works in a bike workshop for the past 30 years from Rambur, who has presented with chief complaints of headache for the past 20 days, cough for the past 2 weeks, fever for the past 5 days, and new onset seizures for the past 4 days. History of presenting illness. This patient was apparently normal until 30 days back when he sustained a head trauma when he opened the car door and he had an injury to his left side of the head. Following this, he developed a swelling over the left scalp and he didn't seek any medical attention for the same. Following this, he developed a worsening headache, which was predominantly localized to the left frontal region, which lasted for 20 days. The pain was continuous and dull aching in nature. Following this, he developed a new onset fever for 4 days, which was high grade, continuous in nature, associated with chills and rigors. Then he developed a new onset seizures, which involved tonic-clonic movements involving the right upper and lower limb, along with turning of head towards the right side. It was a focal type of seizure. This was associated with bowel and bladder incontinence. However, there was no deviation of angle of mouth, uprolling of eyeballs, or tongue bite. Post-ictal confusion was there for around some 15 seconds, and he had 3 such episodes. Following this 3 such episodes of seizure, he was taken to a private hospital, and there he was given anti-epileptics. CT brain done at that time had showed a subgaleal collection, and he was started on IV antibiotics, and then he was referred here for further management. During the symptoms, he didn't have any other complaints like vomiting, blurred vision, or weakness of limbs or loss of sensation. And after admission here, he continued to have multiple focal epilepsy seizures, and he required multiple anti-epileptics to control his seizures. Despite adding 4 to 5 anti-epileptics, his seizures continued to persist in the ward, and there was secondary generalization, and this turned to GTCS types of seizure. And then after 3 days, he went into status epilepticus and the seizures were not under control. EEG had showed a GTCS pattern. And because he had refractory status epilepticus, he was induced with thiopentone and shifted to ICU for mechanical ventilation and further management. After induction with thiopentone, his seizures had settled, and EEG done at that time had showed biplets and Gplets with persistent electrical discharges, but there was no clinical seizures. And multiple assays which are done for anti-seizure medications are always below the therapeutic range. Past history is a known diabetic for the past 7 years who's on regular medication but not under control. There's no history of any childhood seizures or no family history of seizure disorder. Personal history is not a smoker, not an alcoholic. A general examination, he has no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Vital signs, pulse rate was 108 per minute. Blood pressure was 160/90. He was tachypneic and he required 2 liters of O2 to maintain saturation. Temperature recorded at that time was 100 degrees Fahrenheit. On examination, local examination, he had a fluctuant swelling of size 4 x 4 centimeter over the left side of the scalp. There was no warmth or tenderness. Systemic examination, cardiovascular system, S1 and S2 were positive, no murmurs were heard. Respiratory system, crepes were there in the right and left infraaxillary regions. Per abdomen was soft, no tenderness, no hepatosplenomegaly. Central nervous system, he was conscious, oriented. GCS was E4, V5, and M6. Power was normal in all 4 limbs. Sensations were normal. There was no cranial nerve deficit. Deep tendon reflexes were normal, and there was no meningeal signs like neck stiffness, Kernick signs, or Brudzinski's sign were negative. So the timeline of the events were head trauma 30 days back, followed by headache for 20 days, and now new onset fever and seizures for 4 days. So differentials you can. They put in using the code 3586254. Code is 3586254. So the differentials we considered in this individual is the problem complex was a new onset complex partial seizure with headache and fever with a history of head trauma 1 month back. The differentials we considered was a traumatic cause like subdural hemorrhage, extradural hemorrhage, SAH or cerebral contusion, infective causes like meningitis, which could be a tuberculous meningitis or bacterial meningitis, a brain abscess or a neurocysticercosis, or AUFI with ARDS with meningitis like scrub, malaria, dengue, or a stroke. It could have been an ischemic hemorrhagic or embolic stroke, a CNS tumor, or a metabolic disturbance, or an autoimmune encephalitis, or mesial temporal lobe epilepsy. Investigations wise, hemoglobin was 11.3, counts were not elevated, urea creat was normal, HbA1c was 11.7, electrolytes were all within normal limits, BBBS was negative, LFT was within normal limits, and AG ratio was 0.9. UP by UC ratio was 1.84. His ankle jerk and all was absent. ECG did not show any acute STT changes. Distal pulses were present. Fundoscopy was showing early retinopathy related changes. Urinalysis, ketones was 1+, proteinuria was present. ABG, but there was no metabolic acidosis. Echo was normal with normal LV function. ECG was showing normal sinus rhythm and normal axis, no STT changes. He did a CSF analysis for him. The counts were all normal. Cytology was normal. Culture did not reveal any growth. Expert AFB or negative. Protein was 39. Glucose was 72. Cryptococcal antigen and toxoplasmosis were negative. PCR for multiple viruses was also negative. 3 blood cultures were taken, which did not show any growth. Sputum cultures grew only normal flora, and dengue, malaria, scrub were all negative. Fungal cultures were negative. Procalcitonin was 0.11. Initially, we did a MRI brain, which was showing a subgallial collection with enhancing walls, which measured 5 × 1 × 3 centimeter in the left frontoparietal region, and there was no intracranial extension reported in the MRI brain. Chest X-ray was showing bilateral lower lobe infiltrates. Anemia, hemoglobin was 11 grams with iron was 35 and TABC was 367, indicating an iron deficiency anemia. So we couldn't find any diagnosis so far, which reminds us of one of Sherlock Holmes' quotes that when you have eliminated the impossible, whatever remains, however improbable, must be the truth. Next, we went ahead and repeated an MRI brain.
1 minute.
Sir?
1 minute.
3 days later, which showed again a subgallial collection in the left frontal lobe with underlying dural enhancement and frontal lobe hyperintensity. So this was the findings in the repeat MRI brain. Again, initially we had called neurosurgery for their opinion, and they said that the scalp hematoma was not significant. Again, due to persistent seizures, we called neurosurgery again, and this time they did an aspirate from the left frontal scalp swelling, and this culture grew Burkholderia pseudomallei, which was sensitive to ceftazidime and meropenem. The final diagnosis was a new onset focal seizures with secondary generalization, secondary to neuromelioidosis, with traumatic STH and uncontrolled type 2 diabetes with complications of diabetic nephropathy, neuropathy, and retinopathy, and systemic hypertension. So antibiotic course planned for him was an intensive phase with meropenem 2 gram every 8 hours for 8 weeks, followed by eradication phase with Ceftaran DS 160 by 800 mg for 6 months, and multiple antiepileptics. So melioidosis, it is a facultative intracellular organism. It is an infection caused by Burkholderia pseudomallei. The modes of spread, the most common modes of spread is by inhalation. It can also spread by percutaneous inoculation and ingestion of water. The distribution pattern, it's most commonly distributed in northern parts of South America and Southeast Asia and northern parts of Australia. This is a study done in South India regarding melioidosis. 25 cases, or a retrospective study done on 25 cases. And in this study, the most common predisposing factor they found for melioidosis was diabetes mellitus in 68% of the patients and alcoholism in 28% of the patients. Other risk factors was chronic lung disease, chronic kidney disease, and chemotherapy. And this is a CMC study done on retrospective study done among 114 patients with melioidosis, which showed a predominant pattern of distribution of melioidosis towards Southeast India, in Tamil Nadu, Andhra, Jharkhand, and also in West Bengal. Here in this study, the most common predisposing factors were diabetes mellitus in 81% of patients and ethanol use in 14% of the patients. Other risk factors for melioidosis in these patients were CKD and sickle cell disease. The most common organ involvements found was a sepsis with bacteremia. The other involvements was splenic abscess, a liver abscess. A lung involvement was common in 24% of the patients. Septic arthritis in 19%, osteomyelitis in 10%, and skin and soft tissue involvement in 13%. This is another prospective study in Australia regarding melioidosis. Again, here the most common involvement was pneumonia. The second most common was a genitourinary involvement. The third most common was skin and soft tissue involvement or an osteomyelitis pattern.
Thank you very much. I would really like to appreciate all 5 presenters. Fascinating cases, very interesting, and wish we could have more time for each of the presentations, even though each one was at double and triple speed as far as talk time is concerned. I want to also really appreciate Dr. Rohit and Dr. Joseph for using Slido. And it's always nice having some of that interaction, even though it does take a little bit more time. I want to appreciate Dr. Praneet with autoimmune encephalitis, Dr. Rohit with the prosthetic valve endocarditis, Dr. Panicia with oncovasculitis, Dr. Lino with the Osler-Weber-Rendu syndrome, and Dr. Joseph with a new onset generalized seizure with secondary generalization and the challenges that have come with it. For our prize this morning, I would like to go ahead and recognize those that stayed within time. I really appreciate Dr. Lino for taking the least amount of time. However, I did not see much differential diagnosis. So with that in mind, I'd like to go ahead and give our prize this morning.